Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Femur.
Hello. Focus of today's lesson will be the femur. We need to have the entire femoral shaft on there from the knee to the hip joint. In a previous lesson you learned how to do the knee exam. And so today's lesson we're only going to focus on the proximal femur because that's the only new part. We're actually on most patients taking 4 different x-rays, 4 different pieces of film. You're going to have an AP and a lateral proximal femur, and you're going to have an AP and a lateral knee exam. And that's why I don't have to demonstrate the knee today because you've already learned it. So we'll talk about some other scenarios at the end. But let's get a baseline to work from first. We have our patient Jacqueline lying on the table, and we're going to have the femur straight. Her body is straight, and I'm going to have 40 inches to the bucky tray. And we're going to be transversely centered. These are all things that you've learned in previous lessons, so we don't need to focus on those. Make sure your tube is transversely centered, 40 inches to the bucky tray. I have a 14 by 17 cassette in the bucky tray. ID blocker away from the joint of interest. ID blocker away from the joint of interest. This is a floating tabletop, so I just center the collimation with the cassette, and then I'll be floating my patient into the necessary positions. I want 17 inches collimation for the length of the femur, and side to side I'm going to start with the 14 so you can see film size, but you're actually going to collimate down to the patient size, which we will do in the process in just a minute. Part film reference point. The ASIS should be level with the edge of the film. We'll just kind of look at her anatomy for a minute. Here's her ASIS. If you feel on your tummy, you will feel a prominent bone of your pelvis sticking out on the tummy side. That's your ASIS. Here's her hip joint. The ASIS is 2 inches above the hip joint. It is not necessary for you to palpate your patient. Patient modesty would be compromised if you palpated for the hip. So we just use the ASIS. By knowing it is 2 inches above the hip joint, we're just going to put the film's edge level with this point. Again, use the ASIS to the film's edge because you already know that it's 2 inches above the hip joint. Therefore, you're going to have good film clearance. And if you look here, I think we can see, I'm just going to float the tabletop up just a little bit. And now her ASIS is level with the film's edge. Okay? We need to invert the feet 15 degrees. Yeah, you can do both legs or you can just focus on the leg of injury. I had her turn her knee in 15 degrees. What that does is it brings the greater trochanter out and the lesser trochanter goes underneath, goes medial and back underneath that femur. Okay? Now we want the femoral shaft to be centered. The table won't float anymore, so I'm going to have my patient slide to their left. That's good. Keep her straight on the table. This crosshair comes right down the leg, and since I had to move her, I'm just going to double check here to make sure that the table didn't shift. I want to maintain film's edge level with the ASIS, and I'm happy with that. Okay, look at the collimation here. That is 17 inches. You may get this gut reaction that you need to open it up more because you're not including all of the femur. You've got to fight that gut reaction because the principle is the body stops the light, but it doesn't stop X-ray. I'm going to show you something here. Here's a lead strip. And let's pretend Jacqueline just put on 200 pounds. Her leg will stick up higher than this. And see, as the body would get bigger, how small that light will look, you've got to keep that in mind, that the body is stopping the light, but it's not stopping the X-ray. You trust your gauges. The gauge says 17 inches. Okay? Trust your gauge. It says 17 inches. The film is no longer than that. Okay? Trust your gauge. 17 inches. And some students will try to use this edge thinking that this is the film's edge. They will try to use the collimator light edge to level it with the ASIS. They're going to try to do this because they think that's the film's edge. But that student, if you do that, you forgot the body stops the light, doesn't stop the X-ray, and your film's edge is now going to be above the ASIS. You've got to remember the divergence of the light. So, do not expect the edge of the light to be level with the ASIS. I'm looking at my film's edge and my ASIS now. Okay. Film's edge level with ASIS, leg inverted 15 degrees. If I've done a good job here, my evidence will be that the lesser trochanter is barely visible. That's the PC information for this femur. I can push my cassette in now because I'm done with that. I need to collimate side to side, and the size of your patient's leg will dictate that. Bring it in fairly tight, particularly if you're photo timing, and then you can put an R marker on there. Let me just show you what you have to. It's easy to put it on the tabletop, but don't forget that the ID blocker is down here, so I have to bring this R marker up a little ways. Can the camera see that? Okay. And then we shield the patient. Unfortunately, the female ovary is about 2 inches below the ASIS. The female ovary on this side, on her right side, is probably there. I cannot shield it. It is too close to the hip joint. But there's no reason why I cannot shield the other side. Okay? Sometimes you'll have techs shield like this. It depends on your apparatus and the actual size of the shield. But I am protecting one side of her ovaries. And a male, you could have a scrotal cup, or the lead strip could cover up the scrotum there as well. You can protect one side. Okay. That's an AP proximal femur. The ID is towards the knee, away from the joint of interest. Film's edge is level with the ASIS, and the leg is inverted 15 degrees. Your evidence will be the lesser trochanter is barely visible. Now in the field, if I was actually performing this exam, I would change my cassette from a 14 by 17 to a 10 by 12. I would change the cassette, put a 10 by 12 in, and I'm just going to mock this. I would slide the table and I would do an AP knee. 10 by 12 AP knee. You've learned this on a different lesson, so we won't take time today to show you that. Okay? You do your AP and you do your AP. The patient doesn't have to move back and forth in that case. So then I'd turn my patient onto their side, and I would probably do my lateral knee first, because then I wouldn't have to float the table. But we're not going to demonstrate a lateral knee. Again, it was done in a different lesson. And I'm going to move right back to my lateral proximal femur. 14 by 17, ID caudal again, away from the joint of interest. With her in a lateral position now, the two ovaries are one right on top of the other, or the scrotum is right on top of the femur, and so we cannot shield on a lateral projection. So the shield I'm going to put away. My patient knew what position to go into. Turns onto the affected side, and this leg will have to stay behind the patient. It cannot come up and over, because then this femur, her left femur, would be superimposing the proximal end of the right femur. So this femur must stay back. I want the femur, the affected femur, to be straight on the table. Okay. And I want her pelvis to be as close to a lateral position as we can, but keeping this femur back. So most of the time you do not get a true lateral. It's, most patients cannot be lateral and flex this knee back. So you have to kind of compromise off of that. Jacqueline is fairly flexible for me, so that helps in the demonstration. I'm going to find the ASIS, and there it is. And I'm going to put it level with the film's edge. And I'm going to put this crosshair down the center of the leg. The R marker, the collimated field, should stay about the same size as it was on the AP. And I'm moving the R marker up a little bit because I know the ID blocker is down in that area. And I can put the cassette in. And now then, just before I make the exposure, I make one more attempt to get the patient lateral, bring this leg back. And I'm looking at soft tissue overlap in here. Bring that leg back. If I can't bring it back far enough, I may have to let the patient relax. But Jacqueline actually is in a very nice lateral position for proximal femur. And I'm looking for my soft tissue clipping, and I'm not clipping here, nor am I clipping there, so I would be happy with this position. Okay. I'm going to let her relax just a little bit, but I'm going to have her stay in the lateral position. Sometimes it's difficult to palpate for this ASIS. Adipose tissue just kind of drops over the ASIS, which is the anterior superior iliac spine. But you have the upper ASIS, and this can be a backup centering for you. But you must be cautious. The ASISs will not be in the same plane. When the patient goes into a lateral position, the pelvis shifts. And the upper portion of the pelvis, this ASIS will shift as well. And if I can't find the lower ASIS, I can find the upper one, but I must keep in mind that it shifted down. So my film's edge, I could feel for this ASIS, but I'll know my film's edge needs to be about right there if I'm using the upper ASIS as a guide. Okay? Okay, we're going to let the patient relax because this is uncomfortable. If you've done a good job in a lateral position, the lesser and the greater trochanter, one will be superimposed on the other. The evidence you will see on the film, you will see a little bit of the greater showing, you will see a little bit of the lesser showing. Almost balanced if you've done a really good job. Both sides showing just about the same amount. Again, you take 4 projections for a femur, AP proximal, AP distal, which would be your knee, and 2 laterals. We're going to be talking cross-table hips in future lessons. Once you learn the future lessons, you might choose to use your big film for a femur. You might choose to use the big film to include the knee and the 10 by 12 to include the hip. But the end results are the same. When you are performing a proximal femur, you must demonstrate both joints. You must demonstrate the hip and the knee in both AP and lateral positions. Usually it's a 14 by 17 for a proximal femur and performing a knee just like you do a normal femur. And let's say we go back to that basketball player. Let's pretend Jacqueline's a basketball player. Okay? Very long femur. And if she has a very long femur, might put the knee joint way down here. If I were to do a true knee, the mid shaft of the femur may not have some superimposition. So if she was 7 foot, if she was 7 feet, again I'm trying to mock this. Can we roll your pant legs up so they can see what I'm trying to demonstrate? The cassette would go on the bucky tray, but I want you to see the anatomy. Instead of centering the knee joint right to the center of the film, on somebody who's long, I would put the ID to the top and I would offset that knee joint so the knee joint is 2 inches from the film's edge, so I'm getting more of the femur on there. I want to make sure there's an overlap of the femoral shaft in there. And it is okay to get the knee joint low on the film in order to include more of the femoral shaft. And Jacqueline, as a student, is that explanation,
Yeah.
you think that we got our point across on that? Okay. You'll have very few 7 feet people in here, but apply some common sense. Make sure you get both joints and make sure that some of the femoral shaft is overlapped. And we talked about PC information. Let me just review quickly what a knee would look like.
Okay.
An AP knee would have the patella slightly medial, and a lateral knee would have the patella free of superimposition of the femoral condyles. And thanks.